Good evening. I really appreciate all your presence and the valuable time you have dedicated to my talk today. I'm very thankful to SSA also for this wonderful opportunity to share the remaining pieces of my thesis that I couldn't cover in public health model. I actually would like to start this talk with a little story. And for that, I actually have generated some image using AI for a visual aid. This story is about my mother. My mother is a mother of 3, and her eldest daughter is turning 34 this year. And she started working at the tea plantation at the age of 15 and retired at 45. That's 33 years of work as a tea plucker. In her 30s, around the age of 38, I believe, she started experiencing knee pain, and the nerves in her leg became very visible. And by 45, her pain became very severe, but she never went to a hospital because she believed like medicine actually does not work without ample of rest. She continued work. By 45, it was very severe, making it very hard for her to walk and stand for a long time. That's the minimum requirement that needed for the employee to be in the plantation. And then at the age of 48, she almost gave up the plantation work, and she was working as a housemaid in Colombo until I started earning. That is when we came to know that she has been developing osteoarthritis. It is a type of degenerative joint disease that result from breakdown of joint cartilage and underlying bone that actually has developed with a repetitive movement and strain condition in the estate work. At that point, I really wanted to ask her why she didn't go to the hospital, because I was a public health student, which is a pre-medicine degree. Her reply was very powerful. She said this: medicine works with sufficient rest, and I can't afford to rest. What's the point of taking medicine only to return to the same task next day? The pain is going to come anyway. Why should I spend an entire day at the hospital, losing income from work and spending money on private clinics when I knew I would have to live with the pain until I retire at 50? I found it very powerful, and in just few lines, she actually captured the 33 years of hardship that a female plantation workers endure. This story always stayed with me, driving me to dedicate my master's thesis to studying occupational health in my community. With the help of my supervisor, I studied the prevalence, patterns, and associated risk factors of work-related musculoskeletal pain among female tea plantation workers using a mixed method study in Nuwara district, where I was born and brought up. However, when I was analyzing the data, depending solely on a public health model, conventional public health model that uses certain models and certain statistical analysis to explain the associated risk factors, was very insufficient in capturing the real life experiences of the plantation workers. It was specifically challenging to fit the data that was not the choice, that's something that explained the choices of my worker. This was very difficult for me to fit all the data to a given model, particularly when they were sharing very niche narratives about their lived experience, which are directly connected to the political economy and the systemic marginalization that leave the workers with no freedom of choice. At this point, I realized this is actually no point of trying to fit all this data into a very difficult somewhere in the Europe or in a developed country, they have made these models, and that is not applicable in a country like Plantation. So I almost gave up on the models, and I was started writing freely what I felt was right. So as a critical synthesis of my study, it reveals several key messages that actually challenges the conventional public health approach to occupational health and provide a very unique contribution to the literature. While much of the published papers actually advise the certain posture to maintain to mitigate the work-related musculoskeletal pain. I found it very funny because certain postures cannot be achieved particularly among plantation workers, because they work on a mountainous terrain which is uneven. They carry high load of 25 kg of weight. Do you think they'll consider on maintaining a posture? So I actually found it very funny, and this is not applicable. That was my starting point to think differently than fit into a very typical model. This physically demanding nature of their work, which involves prolonged weight bearing on uneven, as I said, very mountainous terrain, very difficult for them to achieve suggested ergonomic postures, which is definitely an impractical solution. Furthermore, the worker's specific pain experiences challenges existing assumption, like in literature, public health literature, if you take they always limit workers' knowledge to lack of biomedical terms. They are not doctors. They are not supposed to remember any of the biomedical terms. Even doctors, I don't think they remember all of it. The workers have specific pain experience that actually challenges the existing assumption. For an example, the pain from carrying the basket on the head actually predominantly felt on the shoulder, which bears the weight, indicating a need for a more in-depth understanding of how forces are distributed in their unique context of work. This study also offers a new perspective on self-pain management, which is contrary of the assumption that a lack of formal education and lack of awareness about biomedical limits workers' understanding of their injury, and my qualitative data almost show that workers have a very deep embodied knowledge of their pain. For example, participants that say like going to this work is going to produce pain. So they really know doing this job is definitely going to cause pain. They could clearly articulate how specific work tasks cause and perpetuate their pain, recognizing its current nature when they continue to perform their duties at work. This actually suggests the issue is not the lack of knowledge, but rather a lack of viable alternatives. This body knowledge, which aligns with Arthur Kleinman's work, correctly identified political economic structural issue, correctly identify political and economic structural issues, not individual deficit, as the true source of injury is from the source of injury is the work environment. So given their continuous engagement in physically demanding tasks, the pain is persistent condition without a readily available permanent cure. This unique perspective underscores the need for a right-based public health approach that actually go beyond the individual behavioral change and address the structural and environmental factors that perpetuate the cycle of pain. A right-based public health will enable us to challenge the biomedical model that silence the workers' knowledge. Actually, the right-based public health model encounter the idea that patients are merely consumer who has the choice for compliance. Instead, it recognizes the rest, not just medication, is essential for recovery. And secondly, actually it addresses the structural causes. The right-based public health approach will compel us to examine working condition and policy failures, the main causes of pain and barriers to seeking help. By adapting this approach, we actually align with scholars who examine health outcomes as failures of fundamental human rights. This perspective broadens the conversation beyond clinical measures, echoing the viewpoints of thinkers like Paul Farmer. His central view was that healthcare is a fundamental human right, and poor health outcomes are result of systemic social and economic inequality. In my research, I actually come across a lot of structural roots of health injustice. While the nation, Sri Lanka, has achieved commendable health indicators internationally, a close examination reveals that the estate sector consistently lags behind other regions having the highest rate of maternal mortality and child malnutrition. A core reason found in the study that explains the disparity in the separation of estate-owned healthcare system from the state-owned healthcare sector. While doing my research only, I was 28 when I understood this. The estate healthcare system is completely separated from the state healthcare system. So that was actually came eventually when I was doing the research. So the continuation of this is what happens. The continuation of colonial legacy that adapted into the neoliberal capitalist in the plantation sector actually reduces the external interference in the estate management. So that includes the government as well. This framework that actually extract both economic resources and health from the Malaiyaha community. Women actually face very intense, low-paid labor as a cheap workforce because they are predominantly assigned to pluck tea directly from the site. This shifts the community into a systemic exclusion, with the government failing to fully take responsibility of the welfare of these people. Consequently, the colonial healthcare structure still persists in the plantation management, which is being solely managed by the estate management. And it is the estate management who assigns the general practitioner. I actually question their qualification too. I'm not sure whether they are doctors, but they are the one who are responsible for the people in the plantation. Actually, it is not the government who assigns the general practitioner in the estates. This reliance on the estate managed healthcare, combined with the hard to reach public facilities, actually creates the two-tier healthcare system as described by Maitri Jagadisan. Workers actually face a lot of discrimination in public institutions based on their ethnic identity as Malaiyaha Tamil, occupational class as estate workers, and historical marginalization that we might in our history came across how this slave trade all happened. As evidence, one of my participants actually said this. Even we managed to pay the tuk-tuk driver 3,000 rupees to reach the state hospitals, we are not treated with respect. The public health practitioner actually scolded us for no reason. They also said it's the fact that they are the estate workers, but they actually expect certain level of respect as they are also human beings. That actually very saddens me as well because I also come from there. The state's more effective healthcare system that is actually established in every region, if I'm not wrong, are often inaccessible to plantation workers due to their remote living location, poor infrastructure, and lack of affordable transportation. I was asking my mother why these households built here, and she said it is built here just to protect the plantation. Actually, we are protecting the plantation. Plantation is not protecting us. The high cost of private transport, as I already mentioned, in order to reach these state hospitals, they have to pay around 3,000 to reach that free state health care, which is again cause a lot of indirect costs for them. Even when they reach the hospital, they face a lot of discrimination. And one more thing that they said is, it's only in a month that we go to a town. We cannot come home without buying anything for our kids. So they go to the hospital paying 3,000 and then they go get scolded. When they come back, they really think of their children and they sacrifice seeking health. So they actually sacrifice it. So the systemic barriers are actually damaging for this population. Actually, it compounding the issue of excess in the fact that many workers experience unpleasant and disrespectful treatment from the estate hired physician as well. So the estate hired physician was supposed to give health services for free. But what he does is, according to my participant, he keeps all the medicines that the estate provides and he sells it for money. When people go to him, he asks them to come to his house and he costs certain charges to give that medicine. Even there, a lot of corruption is happening. This is why most of them actually don't seek proper treatment. So another very sad quote that came from my participant is like, we don't have money and that's why we are here in the government hospital. And if you go to private hospital with money, we also get the VIP treatment. That's true actually. This actually forces them into very difficult choices. Either they endure the pain or they seek costly private hospital care. For that, they have to pound their jewelries. Also, they have to borrow money from someone. Again, that puts them in the deep-seated poverty. The long waiting hours at state-owned facilities, because we have the universal health care, so it's okay to be in the long line because everybody is accessing health. Though it is normalized in the government hospitals, for these people, it is actually a loss of full day's income for plantation worker. This combined with the lack of paid sick leave as well. So they don't get paid when they are sick. They cannot take a day off. Even they get the occupational injury. This creates a very powerful disincentive to seek treatment even for severe pain. My study actually demonstrates the root cause of these health issues deeply embedded in the workers' socio-economic reality. The prevalence of work-related musculoskeletal pain is directly linked to the significant economic pressure faced by female tea plantation workers over the heart of my study, who earn a low monthly income and support a high number of dependents. This financial pressure are compounded by what workers described as double burden of both paid labor and unpaid household responsibility. Most of my people are married, and almost about 96.7% of them have children. Many actually earn only between 5,000 to 10,000 each month while supporting a high number of dependents. These financial pressure actually lead to tough work and living situation. Over the half women work more than 8 hours to earn extra because the 10,000 is not sufficient at all. Nearly 70% of them who participated in my study carry heavy loads of over 25 kgs of tea leaves to make extra money. This grim reality is summarized in a statement. One of my participants said, "Going to work is compulsory since there is no other source of income. If I don't go to work, my kids will starve." On top of this, women are expected to do the household chores even after intensive labor at work. They continue to handle household chores until they go to bed around 10 or 11. They wake up again at 4 or 5 to start over. This is a clear indication of unaffordability of rest that needed for a muscle recovery, which is a recommendation that again comes from public health approach. Also, the lack of affordable cooking gas forces them to gather firewood, leaving no time for weekend rest. One worker actually pointed out, even coming back home, we continue to work. We take over the time, which take over the resting time. This ongoing lack of recovery time highlights the reality of plantation patriarchy, a concept introduced by Rachel Kurian and Kumari Jayavardhana. Our gathered data connects this exhausting schedule directly to why pain actually peaks when they rest. So most of them said, like 22.4% of them said, while waking up we feel very severe pain. That is a clear indication that the rest is not enough for the muscle recovery. This shows how the gender division of labor and intersecting structure of oppression or hierarchies, whatever we call it, such as gender economy, makes it hard for workers to recover physically. Prolonged work hours and repeated movements cause work-related musculoskeletal pain that can develop into serious disorder if sustained. This continuous engagement in physically demanding tasks, despite persistent pain, is not a personal choice, but a consequence of a system that penalizes them for seeking care. The result is a cycle of untreated recurrent pain that leads to chronic health issues, disabilities, and reduced quality of life, ultimately reinforcing the health inequality present in Sri Lankan society. My study revealed a significant high prevalence of almost 62.6 of intense labor of this occupation. Particularly, the finding of this study actually indicate the high prevalence of pain. Over 3/5 of the workers actually reported shoulder pain, while 23% had hand or arm pain, about a quarter experienced neck pain. These issues were closely linked to tasks like carrying tea baskets and repeated hand movements. The workers' qualitative description of feeling like they work like machine further reinforces this link, highlighting the extreme physical demands and lack of resting inherent in the job. I also found a chronic musculoskeletal condition like osteoarthritis, just like what my mom had, with 1.8% of prevalence among you won't believe, among the 20 to 44 age group, despite WHO typically recognizing the onset of osteoarthritis age between as it start actually in the mid of 40 or over. The early onset it actually 50. So this is a clear indication that there is early diagnosis of chronic conditions that actually accelerate from the intensive labor condition, making it a hot spot for disease. So here I actually applied the concept of Alex M. which became very handy for me to explain this. While many workers, including those in the free trade zones, like the garment workers, fisherwomen, shared issues like unpaid sick leave and low wages, the focus of conventional public health on biomedical deficits actually failed to address the unique challenges faced by the Malaiyaha community. This population finds itself in special circumstances where lack of land ownership, residential right to tide, to plantation work make it hard to change job. Because I even asked my mother, like, why are you working in the tea estate? You could find something else. Because it's all the job security that they provide in the name of ETF and EPF. Most of the workers actually depend on that. So my mom worked until she was 48 just to access the pension in the form of ETF and EPF. However, she could do it only at the age of 50. So most of the workers actually work here. They don't. It's not a choice, but they are kept in that way so that they're working in the tea estate just to access the pension money, so that their kids' future and their future is also saved. Some of them actually sadly don't get to enjoy that benefit because most of them actually die of other health issues without enjoying their ETF and EPF. So beyond musculoskeletal pain, I actually find other health issues like nutritional and other comorbidity. I actually don't want to term it as a comorbidity, but there's no other terms that I could find it. So that was also found in this study. The low pay and high work exposure do not just lead to musculoskeletal disorder, but also they broad health deficit. For an example, one is definitely the insufficient diet. The diet of plantation workers reflect significant economic hardship with low wages. Many can only afford 2 meals per day, lunch and dinner. They actually rely on a heavy dinner that actually help them to have the energy till the lunch next day. Usually they consume a lot of carbohydrate, which is the form of rice, and roti, which actually prevents us from feeling hunger. They actually miss breakfast because they actually don't have time in the morning because they really have to rush to feed their husband, to send the kids to the school, and actually they don't find time to have breakfast in the morning. If they have it, that is only a cup of plain tea. So I was actually questioning them, like, if you don't have enough food, how do you actually have the energy to work throughout the day? And they say, like, to compel with the need for a warmth and energy, they rely on chewing betel leaves. Women often actually skip meals to prioritize feeding their children and husband, as noted by Romy Pereira in her literature, showing how low wages trap the workers working poor in cycle of debt and chronic poor health, confirming the finding by scholars like Balasingham Skandas Kumar, Sarala Emmanuel, and Kanchana Ruwanpura. Second is the comorbidities. The demanding nature of labor affected health beyond musculoskeletal disorder, as I already said, and that leads to many other health issues. Workers report severe symptoms like prolonged menstrual bleeding that actually last up to 25 days. Often, this is triggered by carrying a lot of weight. They also experience chronic headaches, respiratory issues like wheezing, and frequent toothache. That is to do with the very harsh climate. So these findings actually add to the, I believe my findings add to the broader discussion, supporting the argument from scholars like Ponniyarasu and Sarala Emmanuel, who show that similar structural economic constraints limit individual choice for marginalized female like fisherwomen across nation. In conclusion, these workers are trapped in a vicious cycle of work-related musculoskeletal pain, driven by a confluence of social economic pressures, demanding work conditions, and systemic health barriers. They are forced to work through pain because of the systemic marginalization, low wages, and the need to support their families, a necessity compounded by the double burden of paid estate labor and unpaid domestic responsibilities. Hence, the occupational health of female tea plantation worker is a multifaced issue that must be addressed through the core lenses of health, economics, politics, and the most importantly, basic human rights. I thank you for listening. I would like to take your questions if there is any.